Okay, I'm sorry. We have one more member from Thailand. Hello. You can rewrite your name. By default, your name is becoming my name. So would you please write your name there? That will be good.
Thank you so much. Good morning, everyone. Can you hear my voice?
Yes, perfect.
Thank you so much.
So as it's time, so let's start. And first of all, once again, welcome to you all. Thank you very much for joining us. Yoko-san is there. Good to see. So this is our annual event, like previous years, every year, this time. We have a good opportunity due to Yokota Sensei because they are organizing this Asia Week every year. And as a part of these activities, we have the opportunity to have the special PHC session. And I think this is a good opportunity for all of us because this is the only annual event where we can meet all our partners in one platform all together. Of course, we meet different people in different time, but this is the time when we can meet all together in one platform. And this is a good opportunity for all of us to know each other's activities and learn from each other. So today we will have our activities reporting from each country. But before we go to our main event, I would request Professor Naoki Nakashima to make a welcome remark from his point.
Okay. Hello, everybody. This is Naoki. Actually, I'm very glad to see you again in this Asian Weeks 2025. So every year we have the meeting in the session in this Asian Week. Thank you for the QAOS staffs, especially the Kikuchi Sensei, Yokota Sensei, Anai Sensei in QAOS. Recently, we spread this activity, portable health clinic activity to all of Asia and also the Africa from the last year in Zambia. And also we have the colleague, Dr. Sharif from Egypt. So, and also we have the PHC cloud system application, cloud application, but right now we have renewal activity in this Kyushu University, PHC 1.0 to PHC 2.0, using modern technology in this field. So maybe, as you say, maybe we can start to use this system from next March, right, Ashir? So please expect to use that also. And today we have a lot of the presentation. Thank you very much for your cooperation and collaboration every time. Thank you.
Thank you very much, Professor Nakashima. Then we will go to our presentation, but before we go to our main presentation, I would like to inform you about the format of this today's program. Actually, we have 7 presentations and 6 presentations. So I would request all of our speakers to keep your presentation possibly within 8 minutes. 10 is the maximum limit, but try to make it in 8 minutes. That will help us to maintain the program. And after these presentations, I have one presentation about one important issue we discussed last year also. That is about the sensor. Sensor is a very important topic for us, as Professor Nakashima always mentioned, that if we don't choose the right sensor, our research will not be meaningful, because sometimes some sensor produce very erroneous result. That's not at all sensor at all. It's like a toy. So we have some study in Kyushu University. So I will make a presentation on that sensors, recommended sensor set. Then after that presentation, we'll have a panel discussion, will be controlled by Professor Ashir Ahmed, Dr. Ashir Ahmed. He will be the moderator of that session. And right after that, we will conclude this session. So this is the process. And finally, at the end, we will have some comment from our colleague here, Dr. Mariko Nishikitani is here with me. So this is the content of today's program. So then now we will move to our presentation. Actually, this is, as I mentioned, this is a good opportunity for us to know each other's activities. Like today, our first, I selected the order of the presentation by the character, the first character. Because like Bangladesh, B becomes first. Don't feel that I'm a Bangladeshi, so I'm giving the priority to Bangladeshi people. This comes in order. A, there is no A, so B is Bangladesh, C is China, I is Indonesia. So this is the order I decided. So, but luckily it becomes Bangladeshi people, they get the first priority. But from Bangladesh side, actually there is two presentation. One presentation will be done by Nusrat. She represents Grameen Communications. We have many activities in Bangladesh, so she will make her presentation. And then we will invite Professor Kimio Kikuchi. She will talk about the Bangladesh maternal child healthcare project. So first, it's Nusrat. Nusrat, floor is yours.
Thank you, Sensei. I'm going to share my screen. Sorry. It is visible, Sensei?
Yes, yes, it's perfect. Thank you.
Hello, everyone. I'm Nusrat, and today I will sharing the activities highlights in Bangladesh 2024. Portable health clinic provided 258,550 checkups till now, including 5,056 and 44 checkup in 2024. The component includes mother and child healthcare, tele-eye care, Genki school campus service, basic PHC service in Malaysia, portable ultrasound camp, and the challenges we face to provide PHC services in our sector. So let's have a look. Genki campus model. We provided Genki campus model service in school campus, and the school name was Radius International School, and the school are now interested to have annual health checkup in every year. Here is some activity picture that we provided the services. And the tele-eye care system. The PHC system, another module is tele-eye care service, and it implement 4 eye hospital, which cover 16 vision center all over the Bangladesh. And the total service was 55,215 this year. There is some activities picture. I'm going to next slide. And the mother and child healthcare. A total of 160 new patients has been registered in this year in MCH project. And we provided 499 health checkup among the mother and babies. And total of 574 pregnant women has been received health care in 2024 until 2024. Here is some picture that we provided the health checkup. And portable ultrasound camp. PHC launched recently a portable ultrasound service. And so far, 77 patients have been beneficiated from this service. And it helps pregnant women to get important checkup without any long travel. Here are some pictures. And basic health checkup in Malaysia, 981 patients received healthcare services until June 2024 from Malaysia. And the recent challenges we faced to provide PHC service. We address few operational challenges like helping children stay calm during their health checkup procedure. We found some autistic children, and it is really challenge to understand and support the patient's unique need. Sometimes the patient get anxious, and it is hard to manage the time to calm them. Sometimes in MCH service, heavy rain and storm makes the road slippery, and it is really hard to visit patients' home to provide the service. And recently we faced internet blackout that disrupt the telemedicine service and online service. And sometimes it is really hard to maintain the server maintenance is really hard if the administrator unavailability. So that is the challenges we faced. And that's all from my end. Thank you.
Thank you, Nusrat. Actually, she shows some challenges, but I think we will not go for question and answer session here. At the end, we will have the panel discussion. So during that period, maybe we can discuss. And I think this is the similar situation in most of the developing country, the challenges we feel. And especially in case of Bangladesh, as they provide the maternal child health care, so there is an additional issue about the maintenance of the babies. So this is getting a big issue, how to maintain that baby at home and take their health checkup. So we'll go for the discussion in the final session. And one point I'd like to mention that you find a huge number, like 250,000 patients are there, and most of the patients are coming from eye care. Actually, we didn't disclose this data earlier. Recently, we got that approval, and now we can share that every year we have more than 50,000 patients in the eye care alone. So this gives a good impact, and it shows the importance of PHC system in the areas of eye care in Bangladesh. And I think the situation will be similar in other countries also, if there is any opportunity. So thank you, Nusrat. And now I would like to invite Dr. Kimio Kikuchi, Professor Kimio Kikuchi, please.
Can you see the slide? Can you hear my
Yes, we can.
voice?
Yes, yes, perfect.
Thank you very much for having me. So today I'm going to share some of the updates of portable health clinic in maternal and child health. So let me at first briefly explain about the project overview. So in 2019, we launched remote checkups for mothers and children using the portable health clinic in Bangladesh. But at that time, we haven't done it as a study, as a research. So in 2022, we restructured this project as an intervention study, and then we designated intervention and control areas, those study site. And since then, we have provided portable health clinic services to mothers and children in the intervention areas. And then we followed up mothers from 16 weeks of gestation to 1 year postpartum, as well as children. And this year, in June, we completed recruitment of new pregnant participants. So now we will follow them until up to 1 year postpartum. And then we will organize evaluation survey in 2026. So this is somehow some of the, I think it's some overlap with Nusrat-san's slide, but my data is as of July 2024. And in total, 548 diets of women and their babies have participated in the project. And then we provided 1,935 health checkups for those women and children. And this also overlap with Nusrat-san's slide. But yes, this is our new initiative, ultrasound screening services. So we have we have done already 3 times ultrasound camps, as Nusrat-san explained. And then out of 62 women who participated these 3 camps, these camps, some of them participated all, some of them only one. But we identified several cases which may have risk of severe complication during a perinatal period, such as multiple pregnancies or malpresentation of fetus or malpresentation of placenta. So using this ultrasound device, this is mobile ultrasound device, we could identify the risk. We could screen the high-risk women and the community, even in a community, and we could refer them to the clinics or hospitals. So this is very beneficial for mothers and our project also. And another initiative is that this is the Professor Nishikitani is now trying to developing a predictive model to forecast maternal and neonatal complications. So this is a statistical prediction model, and we have been using Kyushu University Hospital's database to make a prediction model, especially the data of antenatal records. So the final goal of this model is that to integrate this model into our portable health clinic in Bangladesh so that we can use it in the community to screen the high-risk pregnant women. So we hope we can use it in near future. Another update is that we are trying to explore portable health clinic services in the hospital settings. So we will, in December, we will visit Bangladesh, and we are going to initiate portable health clinic service in this Mountain View Hospital in Dhaka. So the advantage of this usage of portable health clinic in a hospital setting is that there are many doctors who work, who have multiple workplaces, such as different hospital or clinics. So if doctor want consult patient in another hospital, they can use this portable health clinic remotely. So that is really beneficial for doctors and then client also, patients also. So we are trying to exploring a possibility to use this model, like a business model of portable health clinic in different hospital settings to support sustainable healthcare solution. And another update is that we have been collaborating with a Japanese mobile ultrasound company and a Japanese NGO to develop a maternal and child health registration system in Zambia. So this has been conducted in the framework of JICA's project. And also we have been conducted a survey about water quality. So maybe some of you knows that in Zambia, there are some places where water is contaminated by heavy metals, such as mercury or leads. So we are really concerned about these, about the water which were consumed by mothers. So we are sampling the water collected near the health centers, and then we have analyzed if these waters are contaminated by heavy metals. And this year in August, we organized Innovative MCH Approach Symposium at the Social Tech Summit. And we invited different partners from the different corners in the world to hear their activities in maternal and child health or their initiative in their countries. Thank you for your attention.
Thank you very much. Thank you very much, Professor Kimio Kikuchi. And for all our audience, you can understand that there are some multi-dimensional activities in Kyushu University. And actually, as you see the first part of our presentation, that we started ultrasound camp in Bangladesh. We had the MCH program, but we didn't have ultrasound at the initial level. But since we added ultrasound in the service, we find huge response from the people. Earlier, we had to look after the pregnant patients. We had to search by ourselves. But when the ultrasound is added, we find the request from the patient that we like to join in this program because this is a good opportunity for them. And as Professor Kikuchi mentioned, that we find some risky patient, and at least we can say that we could contribute to provide a better service for them. Without this feature, we couldn't have that kind of service. And as you mentioned also that we started our activities also in Africa, in Zambia, but not only directly in healthcare, but indirectly that is contributing in healthcare is water research. Because in many countries, water is a source of disease. So that's why our team has considered it as a very important factor. Actually, when we started these PHC activities in Bangladesh, we find some symptom in water. Since then, Professor Nakashima, she always insisted that we should look into the environment also, because it has a good impact, a great impact on the healthcare. So we started the water testing experiment in Zambia, because there we had report that they have some sort of problem there. So I think this is a part of the portable health clinic, because the one of the concept of portable health clinic is we can provide the healthcare with a portable sensor, portable devices easily. Usually for water checkup, we need university lab where we need big setup for testing. But using the portable clinic, we are trying to find some good sensor, portable sensor that can be used for the water checkup, this kind of, and we had some collaboration with that kind of company. So we started this program. I hope this brings a new dimension to our healthcare services. So thank you, Professor Kikuchi. Now, next we will go B2C. C is China. So we have one wonderful friend from China, Dr. Hu. After a long time, actually, this is the occasion when we can see your face. I wish we can see you more often in the next years. So now it's your turn. So let's see how the activities are going there in China under Dr. Hu. Dr. Hu, it's your.
Okay, thank you, Maluf Sensei. I should see before my slides. I am very glad to see Nakashima Sensei, Maluf Sensei, Malik Sensei, Aisha Sensei, Kik Sensei, and all the old friends. Yes, let me share my slides. Okay. Could you see the slides now?
It's appearing not yet.
Okay. Yeah. One moment. Oh, sorry. Okay, Maluf Sensei, just now I drop off the line. Maybe could you help me to present my slides for me?
Okay.
Okay. Because I think maybe there's some internet connection problem from China side.
Okay, we will make it from here.
Okay.
Just a moment.
Yes, that's fine.
Okay, can you see it now?
Yeah, I can see.
Okay.
Okay, thank you very much, Sensei.
You.
Okay, in today's sharing, I would like to introduce to you the situation and the future plans in our Guizhou province, China, in applying diabetic retinopathy AI screening, hereinafter referred to as DR AI screening technology. I think my sharing consists of three parts. First, let's briefly review some background on diabetic retinopathy. Next slide, please. Yes. Diabetes, as we all know, is a very common chronic disease that affects human health and quality and life. According to the IDF, about 425 adults worldwide suffer from various types of diabetes. And in China, there are about 110 million people who are suffering from diabetes. And in the diabetes patients, about 70% of them will experience tissue damage during their lives. And diabetic retinopathy is one of the most common forms of the complication of diabetes. In China, there are about we do not know the exact number, but in China is also a very major public health public health problem. And next slide, please. Yes. And this slide shows a typical pathological change of DR in the forms of pattern diagrams, including some microaneurysm, retinal capillary hemorrhage and exudate, and retinal edema and other kind of pathological change. Next slide, please. Yeah, and this slide shows the relationship and the DR overall in the first 3 to 5 of the patients in the first 3 to 5 years for the diabetic patients. The Fender's lesion are predominantly mild, and the major pathological change will be non-proliferative lesions. But after the fifth year of the disease, the fundus lesion generally become more serious, and after the 10th to the 15th years of the disease, there will be obvious vision loss or even blindness. Next slide, please. Yeah. This inconsistency between the symptoms of DR and the timing of treatment has led to DR becoming one of the most common complications in diabetic patients of China and the worldwide, with approximately about 40 of the diabetic patients suffering from DR in combination. And the estimated number of patients with DR in Guizhou province is about 800,000, whereas the number of patients actually diagnosis and treat in a timely manner is much more lower than the number of the patients with the disease. That means most of the DR patients, they do not receive a timely diagnosis and proper treatment. Next, please. Yeah. In the second part, we will introduce some preliminary work we have done on DR. Since 2018, we have developed a prototype of the DR AI system in collaboration with universities and hospitals, and we have piloted the application in several communities in Guizhou province, whereas in our experience, community health workers who has a very basic medical education background are able to use this system to conduct DR AI screening only after about half an hour training. Next, please. Next slide. Yes, thank you. We found that the DR AI screening technology is particularly suitable for relative underdeveloped areas. These slides and the next slides are the on-site photos of DR AI screening being carried out in the minority group area in the southeastern part of Guizhou. When we conducting this screening program, many minority elderly people said this is the first eye examination in their whole lives. Next slide, please. And this is a picture of Nakashima Sensei's visit in August. Sorry, the slides is 2018. Actually, the slides is this picture is taken in 2019 in Nakashima Sensei's visit to Guizhou, and we can also see Nahara Sensei. Okay, next slide, please. Yeah. In the past years, we have completed a numbers of DR related technology efforts where we can develop the information system that allowed eye doctors and endocrinologists to remotely to online review AI reports and manage patients and give the patients advices. And on the right, this is our preliminary AI screening report that patient can receive after the screening. It will describe the degree of DR and the suggestions, the medical advices to the patient himself. Next slide, please. We have also developed an online appointment system for patients, making it easy for patients to schedule appointments with their doctors. Next slide, please. Okay. Yeah, this one. Thank you. In order to standardize the DR AI screening work that may be carried out on a larger scale in the future, we also took lead in writing the regulation for the application of DR AI in Guizhou province. And this regulation has been officially delivered as a local standard of our province in April 2023. Next slide, please. And in addition, some of our research results obtained based on the DR AI system research have been published in international and Chinese national academic journals. Next slide, please. Yeah. And at the same time, some of the software we developed based on the DR AI system had been authorized by a number of Chinese national software copyrights. Yeah, next slide, please. Okay, in my last part, I will describe our current work and the future plan. Yeah, on the 16th of last month, we have held the first Guizhou Asian Public Health Seminar, which has attended by about 10 administrative officers and experts from 3 Asian countries, including Thailand, Cambodia, and Laos. And this meeting, I introduced to the participants what I am sharing with you today. Next slide, please. Yeah. Meanwhile, the participating Asian experts also experienced the latest version of our DR AI screening system on site. And this is Professor Sinawa, who comes from Laos. Next slide, please. This is a sample of our latest version of our DR AI screening report. In this version of report, it can shows the exact location, type, and the number of the vendor station, and it contains more useful information for both the patients and the physicians. Next slide, please. Yeah. Representatives from Asian countries are all interested in our technology and discussion their intentions and details of further collaboration. Next, please. Yeah, we plan to establish pilot DR AI screening programs in Asian countries in the next 1 or 2 years, which including training local medical personnel to conducting screening and jointly apply for relevant government funding programs to benefit all Asia people. I believe This is also the wish of Professor Naksima, Professor Maluf, and other friends and colleagues of the whole PHC programs. And we welcome all the colleagues of PHC programs and the QC universities to communicate and collaborate with our team. That is all my sharing. Thank you very much.
Thank you very much. It's a wonderful presentation and very important study, we could say. I feel very greedy to use your technology in our system in PHC, because in Bangladesh, we have both iCare and, of course, NCD. So in future, I would love to see how we can collaborate and use this technology in our PHC directly, as you mentioned. Thank you very much. It's wonderful activities.
Thank you, Maluf Sensei.
So next, I would like to invite our colleague from Indonesia, Dr. Lutfan. Dr. Lutfan is here with us. So it's your turn, Dr. Lutfan. Thank you.
Yeah, thank you, Professor Ma'ruf. Yeah, I'm here with um, sorry. Can you hear my voice?
Yes, perfect,
Okay.
perfect.
Yeah. So I thought I have a problem with the connections. Yeah, I'm here with Hanifa. So we would like actually to update what we have done so far. Our main activity right now is to scale up and also to maintain sustainability. And one of the strategy which is in line with what the Ministry of Health is doing right now is actually also to work on the interoperability. So right now we focus on introducing the interoperability work, especially also to support the idea of introduce the what so-called personal health records. So yeah, just to brief you about the situations in Indonesia that now the Ministry of Health actually adopted the standard data exchange called FHIR, Fast Healthcare Interoperability Resources, which is a global standard for data exchange within the healthcare. And now we focus on doing this also to support the interoperability platform in Indonesia, which is called Satu Sehat. And later on, we'll also able then to, if we already implement this, it will be also able to introduce the personal health records that allow patients to see their record, and will be also very useful to have engagement with them. So this is the milestone of our personal health record. We actually started about 3 years ago in 2021 with only 3 primary health cares. But nowadays we already cover about 30 primary health centers, and also try to link with other health level also in the hospital as well as in the referral hospital. And we have been actually engaged with several health office, especially in Gunung Kidul, which is have about 25 primary health centers. And now we are on the stage to test it, the FHIR standard, enable to allow us to link with Satu Sehat platform, which is from the Ministry of Health. So yeah, just to show you that at the first stage, which is about 2 years before, we implemented portable health clinic in several health centers. It was actually 3, and then later on move also to others, and in total there are 7. But nowadays we have 30, and at that time we focusing on community-based health workers and also try to interoperable between the community health workers with the doctors in the primary health centers. And in this states, actually, we are able to link our system, which is used by the community health workers, that will link also with the system, the electronic medical record system in the primary health centers. And this has been done for about 2 years right now. But now we try to move forward that the data will also interoperable with the hospital, especially the hospital within the Ministry of Health, which is will be used if any case have to be referred, then it will be sent to this hospital. And the idea is that the data from the portable health clinic and can be actually accessed in the primary health centers, and later on will be also able to be seen by the responsible doctors in the secondary or even tertiary hospital. And to do this, we adopt the FHIR, the fast healthcare interoperability resources that expected to support also the continuum of care. So if it is ready, then it will be integrated and also interoperable between different health facility. And later on, which is expected next year, we aim also to open the data to the patients, which is actually in line also with the program from the Ministry of Health. It's called personal health records, that the patients will be able also to see their records using their mobile applications. And we have actually tested in a limited scale, but it seems it's very promising. Just to show you some of the features, which is actually similar with others, I think, like there is health screenings and also other medical data as well. Sorry. And yeah, so now we have actually already have a system which is linked between PHC and at the primary health center level. And now we are doing work to be able also to be access and interoperable with the hospital. This is just to show you that in the primary health centers, they can actually see the patient data also. Those doctor who responsible for the patients then can actually have access to this data. And we try to use the use case for this interoperability initiative. Just for example, that some patient maybe need to be referred, and this is one of the use case that we have tested. So the patients that come to the primary health centers will be checked up, and if there is any case that need the expertise from the specialists in the hospital, then the data can be sent to the hospitals, and it will be then refer back. And if there is need to be physically referred to the hospital, then the hospital already ready and also have the patient data on their record as well. And the data will also be recorded and will be able to be seen by the patients at their mobile applications. So yeah, this is the idea, and now it's still on the early stage, but we have tested, and it seems it's promising, and we will continue this, and hopefully in the next year, then this interoperability idea can be implemented in the real field. But this just to show you some of the health facility that actually engage on this process, as well as the activity to engage the stakeholders in health offices, as well as in primary health centers. and we actually also engage with the community, which is at the community level. And this is some of the pictures that been recorded related to the checkup at the community level. And all of this data expected then to be integrated and will be also useful to support the continuum of care. So this is the spirit that we use, that our priority, our focus is actually to support the national health priority agenda, and also to able to engage with important stakeholders like the health professionals within the health sector, health at the policymakers, and also the community. And the idea is also to be integrated with all of them. So I think that's all, a little bit update about our situations. Thank you.
Thank you very much. Thank you very wonderful activities. You started with 3 health centers. Now you cover 30 health centers. So wonderful, wonderful. And we're very happy to see that you are also considering the data interoperability. So you are working for the standardization. So I just feel one thing, maybe we'll discuss later on. In Kyushu University, we also work with the PHC standardization. We are also implementing FIRE here. So sometimes I feel this is a duplication of the same thing. We are doing the same thing in different places. On the other hand, it has some good impact that different people has different experience. So if we can share our experiences, then it will help us, and we can do some interoperability using your data and our data. So that can also help. But at the same time, if there is any opportunity that we work together, because inventing the same wheel by different people doesn't have any sense. So I'm not sure what is the best way, but I think we can discuss, and it's good to see that you have a good development on that direction. Thank you so much. I understand Professor Nakashima will leave soon. So before we go to the next presenter, Nakashima, do you have any comment, short comment?
Oh, thank you very much. Thank you, everybody, for the excellent presentation. I have one question to Nusta.
Yes, yes, Prof. Yeah.
And that one. Yeah, okay. To that one also. I think you have the activity of the IPS, FIRE, HLSM FIRE IPS, right? So, and did you attend the IPS Connectathon in Taipei?
Yeah, we were of this event, but yeah, I have actually others activity at that time. But we at the national level, we actually also try to use this IPS system, especially for Hajj. There are a lot of Indonesian people that come to Mecca for Hajj, and this is the idea is also to adopt the IPS system.
Okay, thank you. Because because your project is really nice, so I think you almost are very close to establish the IPS FIRE IPS project, the system, I think. Okay, thank you very much. And I have another question to nurse staff and the Kimio. So, the echogram is one topic right now, so it's very nice. But I still very interested in the hemoglobin checkup, because in the delivery time, the anemia is really high risk factor, right? So 10 years ago, when we conduct a health checkup for the thousands of the citizens, we made the hemoglobin checkup also, and we provide iron tablet. And also the anemia condition got improved very much, right? So right now, did you made a health checkup of the hemoglobin?
Yes, of course, the hemoglobin is one of the contents of our portable health clinic, and then we provide tablet to women just for first 3 months, I think, and then for their sustainability, we haven't provided for more than 3 months. But anyway, yes, we will be providing.
And did you have some effect on hemoglobin and also on the delivery? Maybe.
Yes, I think I didn't show today the slide, but the number of anemia, percentage of anemia is decreasing as the time of delivery approaches. I think there was such kind of data from our side.
Okay, and how about some kind of delivery trouble
It
or
is not
some kind of drug? Yeah, I
yes,
think it's very
because
difficult to see that.
yes, because that we do not follow the delivery itself. Delivery is at the clinic, and we cannot
Okay.
follow them. So
Okay,
yes,
but
that
you
is
know, yeah, I want to say everybody because you know iron tablets is very cheap and very effective on the anemia. So I think I recommend the health checkup of the hemoglobin for the young female, not only the also the every young female.
yeah. That's good idea. Yes, yeah. Maybe we will try to have a camp with high school students, female high school students, to check their hemoglobin status. Yes.
Sometimes we can find extremely bad anemia in the young female. Sometimes less than 6.0 gram per deciliter. So yeah, I recommend. Thank you very much. But
Thank you.
I have to. Thank you very much. See you again.
Thank you.
Thank you
Thank you,
very
Sensei.
much.
Okay, then we'll move next. Then we'll go to Malaysia. We have wonderful friend, Professor Helen Lesenberg. So, Professor Helen, it's your turn.
Okay. Can see me?
Yes, yes, we
All
can see your
right.
slide.
Can see
Thank
my
you.
slides?
Yeah, it's perfect.
All right. Okay, so thank you. Good afternoon to all the esteemed speaker. Thank you to Professor Nakashima, already left, and to the team from Kyushu for inviting us to Malaysia to join this Asia Week. Yeah, let me see. Okay, next. All right, so I'm just going to recap how the progress of this portable health clinic in Sabah since the introduction in 5th of February 2020. And actually after that, we did start using the PHC online system in May 2021. And then we had that problem issue on offline, and we started the offline system in May 2022. And we renewed our license actually, and it's going to expire in July this year. Already expired, and we have not renewed it, which I will discuss later why is it so. And during this time, we have a joint research agreement with Kyushu University and Grameen Communication. It started on the 1st of July 2020, but it was delayed. We didn't do much because of the COVID, and it's going to expire on the 30th next year. So I hope we can do something before that. So just recap, for those who have not been to Sabah, we are there, Japan and Bangladesh. And just for perspective so that we understand why when you see Bangladesh, we have so many cases, like 200 over cases you all have seen. And for Sabah, Sabah's size is half of Bangladesh, half, the size. But the population of Sabah is only 2% of Bangladesh. The population of Sabah is only 3.5 million. So it's very spread out. So we have to go all over the place, and there's only few people. We will only be able to see few people. And for this cooperation, we have decided to focus on the poorest area in Sabah, although we are doing other areas, which is in Kudat. And this year we are still doing, but I think this year in the portable health clinic up to 900 plus only, but total in our database since we started in late 2021 is only 1,394. And you understand, each time we go for our clinic, we only see each time is only like 50 to 100 people. And I think this is how we do. We move to a clinic and we do it in a community center, something like Indonesia, what Indonesia is presenting as presented by our colleague Lufan. Yeah. So that's how we do. We see the patient and record them, and then give them medication, and then treatment, and give them follow-up. If we discover that they have some problem, for example, high blood pressure, or we refer them to the nearest hospital. So just the advantage, actually, we are very grateful because at that time, we don't have community, the hospital, we don't do any community outreach. But then we were awarded some money, a grant, and then just at the right time, we met a Kyushu University team, and we started this PHC. And because of that, we managed to collect data, because previously all our outreach clinic, normally we just go and come back and we don't really have data kept. So that was very good for the PHC, and we hope we are in the process of collecting all this data and hope analyzing it. Hopefully before the end of the joint research agreement, we will manage to publish at least one paper, and we can proceed with this, because there's a lot of advantage by the data collection. So as we Malaysia is slightly different in the sense that everything is given free. That means when a patient go to see a doctor in Malaysia, they only need to pay 1 ringgit. 1 ringgit is how many? 1 USD is about 4.5 ringgit, So it's only like 25 cent, So people are not willing to pay. So you have to give them free. So of course we need financial sustainability and to continue with PHC. And that's why I'm listening to team from Indonesia, where eventually they managed to get the government to sponsor their project, the portable health clinic. And so the way for us to move forward and to continue for this, if the Ministry of Health or the Ministry of Higher Education give us grant and show that this is actually a very good project. So I think that is the main thing that I want to present today. Thank you very much.
Thank you very much. Thank you very much, Dr. Helen. And it's very good to see that PHC is working in every areas. So it's wonderful, Indonesia, Malaysia, and all other countries where we have put our foot. So we're happy, and we like to work, we like to continue our work. You said that the agreement will be ended by the middle of 2025, but definitely we will extend that agreement. We like to work with you for a long, long time. So don't worry about the deadline, but let's work for the renewal. And Yokota, since he's there, he's the right person. He is always doing this kind of important thing. So I hope we can extend it. Thank you very much. Then in this session, we have our final presentation, and this is from Thailand. And we have our wonderful friend, Miss Saw. So I would request her today. Actually, we were expecting Dr. Tanwan to attend this, but unfortunately, she got engaged with some urgent issues. So the young friend, Miss Saw, will represent her, and we learn about their activities in Thailand.
Thank you so
Thank you.
much, Dr. Rafi. Can you hear me?
Yes, perfectly.
Okay, please allow me to share my screen. Can you see my screen?
Yeah, it's on now. Is it, can we make the screen bigger? It looks, the screen is small.
It's okay now?
It's okay, but I think it's not full screen. I'm not sure. But I think it's
Uh-huh.
visible. It's visible. You can
Yeah.
can go. You can go.
Okay, thank you so much. And hello, good to see you, everyone. And thank you for giving Unicenter AIT for giving this opportunity to be participating in this Asia Week. And as Dr. Rafi explained, actually, Dr. Tanawan is supposed to be present here today, but unfortunately, she is not available. She's having other urgent issue, personal things. So I'm very honored to be presenting about Genki Campus initiatives for redesigning health and well-being of sustainable academic community at AIT on behalf of Dr. Tanawan. So first of all, let me introduce myself. My name is Saw Teng Teng Ted, and I'm Program Operation Manager at Unicenter AIT. So today, and I'm going to go through these agendas. And the first one is Introduction to GCI, Genki Campus Initiative. I believe everyone's already know the system of GCI. And the second one is Framework of GCI at Asian Institute of Technology. And the third one is Timeline of Pilot Program Launching. And the next one is Phase 1 of Pilot Launch Activities. And Phase 2, Full-Scale Social Business Model and Way Forward. So what is GCI? I believe everyone already know about this. So let's imagine a campus where health and well-being are prioritized and students have easy access to quality healthcare. So for many students, like navigating the complexity of healthcare can daunting. So limited access to healthcare facilities, long wait times, and high costs can hinder their ability to maintain optimal health. So the Genki Campus Initiative, a pioneer effort at the Asian Institute of Technology, is transforming the way for students approach healthcare. So by leveraging the technology and community partnerships, and we are bringing affordable and accessible healthcare directly to the campus. So our telehealth solutions empower students to take control of their health through a combination of wearable sensors and remote consultations with healthcare professionals. So we can monitor vital signs, detect early warning signs of health issues, and provide timely interventions. And moreover, GCI offers a multitude of benefits for AIT students regarding to convenience, access to healthcare service right on campus, saving time and effort, and early detection and early identification of health concerns allow for prompt treatment and prevention of serious complications and personalized care. So GCI offer tailored health advice and recommendation based on individual needs. And students can reduce the healthcare cost by affordable and accessible healthcare options. So by prioritizing health and well-being, we're creating a thriving campus community where students can excel academically and personally. So GCI is a step forward, a healthier, happier, and more productive future for all AIT students. So this is the step-by-step activities for the phase 1 pilot launching activities. First of all, we provide a pre-assessment survey, which can gather baseline health data from the AIT community, including students, faculties, staffs, and vendors, and faculties, family members as well who are staying in the campus. And the second step is from the survey that we receive, we select 20 students balanced by gender and nationality, and 10 faculties and staff members, and 10 unit center employees were selected to participate in this pilot program. And the participants were divided into 2 groups, 34 fasting individuals for blood glucose and cholesterol tests, and 8 non-fasting individuals for appropriate result interpretation. And the next step is health checks were conducted using portable health clinic system and measuring key indicators such as blood glucose, cholesterol, and vital signs. And the next step is participants receive the personalized Genki maps that I'm going to explain you later in another slide, and visually displaying their health status to track their health and seek further medical advice from the professional health providers and the doctors. So, and then the last step is a feedback form was distributed to collect participant insight and experience. So this is a system flow and framework of a Genki Campus initiative at the Asian Institute of Technology campus. As you see, the first step, the selected AID students and staffs can get the access of portable healthcare clinic through PHC sensors, and we provide the Genki map through green, yellow, orange, red, the display Genki map, and by identifying their Genki map, we give the consultation by the healthcare workers, for the normal participants, for the normal health decision participants, we give them to follow up at 6 months later, and for the not normal participants, we give them to follow up at 2 to 3 months later. So this is about the Genki map that I want to explain in more detail about this. So to empower the individuals to take charge of their health and participants in Genki Campus program, everyone received the personalized Genki maps as you see in the screen. So these color-coded graphics visually present a person's health status, providing tailored advice, and when necessary, they got the referrals to clinic as well. So the innovative concept of this Genki map was pioneered by the UNES Center at AIT, solidifying our intellectual property in this field. So by leveraging the insight gained from the Genki maps, AIT management do make the informed decisions and allocate the resources effectively to address the specific health needs of the campus community. So this is the Genki GCI medical report for the individuals who participated in our pilot project, along with the Genki map as you see in the screen. So this is a timeline for the pilot program launching. And actually, we have done the very first pilot program in 2022, March. And this in September 10, we relaunched again the second pilot program at AIT with 40 residents. And we are going to have the full-scale program in December. With the evaluation of pilot phase outcomes and plan for the full-scale social business model in the campus. So this is for the full-scale social business model for the large scale in the campus. So to extend the benefits of the Genki Campus initiative to an entire AIT community, the program will be scaled up to include all the campus residents. Not only students, not only faculties, everyone who is living in the campus. So regular health checkup will continue to be conducted using the efficient PHC system, ensuring a larger populations can able to access to this preventive healthcare. So these personalized Genki maps will be widely adopted, empowering individuals to take ownership of their health and make informed decisions. So by analyzing the collective Genki map data, AIT management will gain valuable insights to optimize resource allocations and implement target health interventions. So to continuously improve the program, feedbacks from participants will be carefully considered and incorporated into future actions. So this is a way forward to ensure the successful implementation of the Genki Campus initiative in the campus. Several key steps will be taken. Regarding to the community engagement, we will actively network with the stakeholders to distribute registration forms and encourage participation from the entire AIT community. So regarding to the infrastructure development, in the collaboration with AIT Clinic, which is currently operating, dedicated space will be established for the regular health ticket. We propose to have 2 times per year. Regarding to the data management, a robust data management system will be implemented to efficiently handle the increased volume of health data. And regarding the impact assessments, regular reports and presentation will be shared with the AIT management team and the research group and relevant stakeholders to highlight the impact of initiative and inform future campus well-being initiatives. So for the continuous improvement, annual program evaluations will be conducted to identify areas for the improvement and optimize the program effectiveness. So for the expanding the impact, we are planning to collaborate with the stakeholders and to explore opportunities in other campuses in Thailand, where Social Business Center are residing, such as Chulalongkorn University, Kasetsat University, and Payep University, and Nida University. So like for now, we already launched the Genki Campus pilot program in Asian Institute of Technology and Chiang Mai University. So these are the way forward for the GCI Genki Campus initiative. Thank you very much for your kind attentions, and thank you so much.
Thank you very much. Thank you very much, Ms. So. It's very good to see that your Genki Campus program is running very well. I'm very happy to see your Genki map. This is very helpful to understand, easy way to understand the health status by each individual. And it's more interesting to see that you are working for the social business model, implementing the social business model for the service. So we would love to know about it. I think Professor Ashir will focus on it during the panel session. So thank you very much for your nice presentation. Well, with this, we have our first conclude our first part of individual country representatives, their activities report. Thank you all our speakers for your nice work, and we could learn from each other what, and we know that where PHC activities in which level they are working. And now I will make one presentation for you on behalf of Kyushu University. As I mentioned that we think that there is a very important component in PHC is the medical equipments. Because the data we are collecting in different country, if we use the different level, different quality of sensor, then it will be difficult for us to do some comparative study. And that's why we need to make a standardization of our devices. So in Kyushu University, what we are doing, we are trying to collect different medical sensors from different countries, especially where we have the PHC activities. And in Kyushu University, we are conducting a sensor evaluation study here. So from that study, we will try to find which sensor we can use and which we cannot. So that is the motive of this study. And I think this is important for all our partners because they need to use the sensor that we can use here. So in case of sensor, in case of portable health clinic, we always, when we select a sensor, we try to consider 3 criteria. Number 1, the sensor should be very lightweight and small. Otherwise, we cannot accommodate it in the box because we need to bring the sensor to the village where the health worker can bring the portable box to every home. So it should be small and it should be lightweight, number 1. Number 2, it should be cheaper. If we cannot have the cheap sensor, the service will be expensive, and that will be a big issue for us because the client we target, they are the low income or middle income people. So if we use the expensive sensor, then the service will be expensive. So we try to minimize the cost by using the low cost sensor. But at the same time, we are very ambitious to have the good quality sensor, low price, but good quality. This is a very challenging part. So because if the data is not accurate, then we will not have the right information of the patient. And especially for the teleconsultation, when the doctor cannot see the patient in person, they need to depend on the data shared from the remote site. So data should be accurate. So this challenge, to face this challenge, we have started this study. And if you think about this kind of portable sensor, the sensor is used in developing country and developed country in a different way. If you think the developed country, developed world, how they use this kind of sensor, they usually use for individual home use. For this purpose, this can be okay because they have the hospital facility, they have the healthcare facility. So whenever they find any kind of alarming situation, they immediately contact to the local hospital. So it's okay for them to use, even there is some kind of error in the sensor. But in the developing world, usually these small sensors are being used for commercial purpose, for public community use. Like in many rural villages, they use this sensor for their community clinic, or even some diagnostic center, they don't have big instrument. They use this sensor for their diagnosis purposes. And of course, in some cases, telehealth services, they use this kind of sensor. So you can understand that in case of developing world, the quality of sensor is more important than the developed world, because they have some, in developed world, they have some alternative, but in the developing world, the people are very much dependent on this sensor. So that is why the quality is very important, and especially for our telehealth service. And in case of telehealth service, you know that we collect the vital information from the rural site using this sensor, and we share the data to the remote doctor. So doctor needs to rely completely on the data shared by the health worker. So if the data is not accurate, then doctor will be in trouble to identify patient health status. And of course, the patient will also be in trouble. So for that purpose, we have a special focus on the quality of sensor. And especially for the portable health clinic box, we have different sensor, but especially the red mark 10, 11, 12, and 13. These 4 sensors are very much sensitive because these data are coming from the strip, coming from the blood sample. So we are very much worried about the quality of these 4 sensors. But if we go to the market, you will find a good number of sensors. There are a lot of sensors. And unfortunately, in some cases, you will find that these devices are not recommended by the country or by any standard body. But normal people, they don't understand. Whenever they go to the market, they find some sensor, and they'll find some people choose by their price. Some people feel, I cannot afford the expensive one. So if I find a cheaper one, I will purchase it. And some people feel that maybe I would better to, those who have the affordability, they feel I would better to buy the expensive one. Maybe this is good. But actually, the fact is, none of this is true. Because sometimes the price doesn't represent the quality of the sensor, quality of the data. So that's why we took this as a very important issue, and we started a research, and we collect the sensor from different country, and we compared that sensor with the standard of Japanese pathological laboratory standard. So when we compare the clinical pathology standard of Japan and compare with the strip-based sensor data, and if we find that the data, the error rate is within a range, actually we consider normalized root mean square error is 0.15 as the benchmark. If the error between these two data is below 0.15, then we consider it is acceptable. But otherwise, we don't recommend, in general, we don't recommend that sensor to be used in PHC. So this is the protocol, how we evaluate the platform, evaluate the sensors. But for this checkup, we have used this methodology. As I mentioned, we compare the Japanese Clinical Pathology Laboratory. And for this, we consider the subjects. We are conducting the research in a laboratory where they have the regular customers. Basically, the clients are 20 plus. Basically, the aging people are coming that center. So mostly our sample are 20 plus age group. And for every test, we take at least 50 to 100 subjects for our checkup, for our evaluation. So following this methodology, we conduct our checkup. And now I will show the result of this our checkup. So this is the result of our checkup. If you see, then you can compare what we started this checkup in 2020, but by now we have tested more than, I think, more than 100 sensors from different countries. So in case of blood glucose sensor is very common. In every country, you will find a lot of sensors in the market. So what happened, we collected different sensors from different countries. There are some from Indonesia, Malaysia, Thailand, Bangladesh, India, and many other countries where we visit. And we collected it through our partners. For this experiment, we tested this sensor. Actually, the testing process is still underway. We have still many sensors in our hand. We are conducting the sensor continuously. So these are the sensors that we have already tested. And this is one, base tech is one sensor. This sensor was collected in Bangladesh, but I know that this sensor is available in many Asian countries because this is a product developed in Taiwan. So, but the protocol is based on German, but it is produced in Taiwan. So it is a low-cost sensor. And if you see the graph, in this graph, the x-axis shows the Japanese clinical laboratory test result, and y-axis shows the portable, in this case, base checks result. So you can understand if the result is accurate, it should be always in the central line, central yellow line, all dots should be there. But for this case, we can see that most of the data are above the line. It means that it shows more higher value than the standard result. So this is the case of this. So that's why if you see the bottom, that normalized root mean square error, it shows 0.28. But earlier I mentioned that our acceptable range is 0.15. So it is above 1.5. So we think that we should use this sensor for blood glucose. This is a multi-purpose sensor. Actually, we can use it for blood glucose. We can use it for hemoglobin. We can use it for cholesterol measurement also. But in case of blood glucose sensor, this is not acceptable. In the same way, this is the BioLand. This is another sensor. It is also collected from Bangladesh. Actually, I had the access in Bangladesh more, so I tried to collect most of the sensor from there. Also, I collected some sensor from our partners from other countries also. But many of that sensor are available in Bangladeshi market. It means these are equally available in other countries. So if you see this sensor, it has the normalized root mean error. From the graph, you can see this also shows the higher values there. So here, the root mean error is 0.22. So it means that it is not acceptable in the same way. Then if we go to the next one, Easy Touch GCU, it is very common in Asian countries, but the same way we cannot accept it, 0.20. If we go next, it is EasyMed Plus. It is also available in many countries, but especially in Malaysia, they are using this one. In this case, it's slightly above 0.16. So again, it's not within the range, but it's close in case of blood glucose. But this is also multi-purpose. Let's see other one. Medisafe is one Japanese sensor, and in this case, you can see that result is very close to the line and very accurate. And normal root mean error is 0.11. So this is one of the sensors that we can recommend. We can use this sensor. So I will go faster. This is another sensor. This is also Japanese sensor. It is also good. Error is 0.07, very much acceptable. Then EcoCheck Guide. EcoCheck has different model. EcoCheck Guide is one. This is 0.09. So this is also very good, and we can use it. We can recommend it. Then Aqua, this is also one Japanese sensor, but somehow its result is not within our acceptable range, 0.17. So we don't recommend this one also. Then EcoCheck Instant S. This is another commonly used in most of the developing country. EcoCheck group is very popular all over the world, so I think it's easily acceptable, and its quality is very good, 0.06. So it is acceptable. And the same way, EcoCheck Active, it is also very much good, 0.07. Then EcoCheck Instant, this is also acceptable, 0.08. So these are the sensor, but this is a Gluco 1. This is from India. Unfortunately, it didn't pass our criteria, 0.22. So we cannot recommend this. And Concept is another one, we cannot recommend this. Then EasyMed Plus 0.21, we can recommend this. And this is one, we collected it from Zambia. Actually, in African country, they use this kind of sensor. And we find this is acceptable, 0.14, so we can recommend this. So you can see from this list, the 15 sensor we tested, and out of them, top 7, they passed the criteria because the normal root mean error is 0.14, the highest, within 0.15. So these are the sensor that we can recommend. So that's why we will ask all our partners, please try to check whether any of these are available in your area. If you have this sensor, we'll recommend to use it, number 1, number 2. So go gradually. If you find number 1, try to use it. If number 1 is not available, go for the second. If not, go for the third. So this way, we will recommend all our partners to have a look, because we didn't have the opportunity to look your local market. So you can check it. If you find any of them, then we can use it. So please consider this. I will share this data later on so that you can have a look to your local market. In case of blood glucose, actually there are many sensors that you will find available in your market. But in case of cholesterol, we have very limitation. We find only 7 sensors all over our countries, and only few of them are acceptable actually. In case of cholesterol sensor, the best check we find earlier, we couldn't use it for the blood glucose, but it is also available for cholesterol. But in case of cholesterol, it shows again 0.18. It's not within our acceptable range. That's why, in general, we don't recommend it. If we go for the EasyMed GCU, it is also the erroneous. You can see how scattered the result. How can we use it for healthcare? It's simply a toy. It cannot be used anywhere. Like if you see, if the Japanese standard, it shows the 150, but this sensor shows it like 350. How come? So this kind of unusual data produced by this sensor. So no way we can use it. We can recommend it. In the same way, if you see the EasyMed Plus, it has the same problem. No way we can recommend it. We find another one, AccuAnswer SAW. It is available in Asia as well. It was originally collected from USA, but it has also the similar problem, 0.19. So we cannot recommend it. If you see Easy Touch, it is not acceptable. If you see Core, it is collected from USA, it is also not acceptable. But this one, we collected it from Thailand, and we find a wonderful result it produced. It is also from Accu Group, AccuTrend Plus, and it produces 0.05. So it is very much within our acceptable range. So this is the only sensor we find in case of cholesterol, that this is the only sensor that was within our acceptable range. But unfortunately, as there is no other option, that's why we consider the best check and AccuAnswer. These two can be used for cholesterol if EquiTrend Plus is not available. So we don't recommend that 2 and 3, but if there is no other option, then we can use it. But our recommendation is for number 1. So I would request you all to check this sensor also, any of them. If please try to check number 1. If it is available, please use it. Otherwise, you can go for 2 and 3. In the similar way, in case of hemoglobin sensor, we have 5 sensors. I will go first. This is one sensor we collected. It collected from Bangladesh market, so it must be available in other Asian market also. And it produced remarkably good 0.13, so it is within our range, so we can use it. But EasyMed GCU, this is not acceptable. Slightly EasyMed Plus, it's 0.16, cannot use it. If you go AccuAnswer, it is not acceptable, 0.9. If you go Mission, this sensor is coming from India. I think this can be available in other country, but I didn't find it in Bangladesh. But you can check if it is available in your country, because this is also a sensor should be available in Asian market. So this produced a very good result, 0.06. So this is one of our first priority. And Easy Touch GCHP, it's not acceptable. If we go, this is also another commonly used globally recognized HemoQ. This produced 0.05, so we can use it. This is also recommended. But the thing is, this is very expensive compared to the previous sensor I showed it. It is 100 times expensive than the local commonly used Asian one. So maybe it's not affordable if we consider the service of the PHC. This is another sensor. We collected it from Africa. This also produces 0.06. So this is also very much a recommended one. And this is also little expensive, but not like HemoQ. This is one option. So the top four sensor we can use. As I mentioned that you can see the price. The prices are there already. So like BeriQ rate, it is just $54. But if you go for HemoQ, it is $1,500. So how come we use it? So some sensors are more, so this is the price. So from there, that list, you can check your locality. If you find the number 1, number 2, number 3 or 4, whatever you find, start from the number 1. If you find it, please try to use it, and we will recommend that. And finally, I will show the sensor of uric acid sensor. We find only 5 uric acid sensor, and this is the result. EasyTest Plus, it's not acceptable. You can see the dotted, so scattered. EasyMed GCU, it is the same. It doesn't, we cannot accept it. In EasyMed Plus, it's 0.19. It's also not within our acceptable range. And if you go Sure 2, we collected it from the American market. It was there. And this is the only sensor we find that produces the acceptable range, 0.13. So this is the only sensor we find in our study in case of uric acid. So there was no other sensor. But the thing is, when we try to find the US Share 2, second time we look at in the US market, we find this is not available. So this is one of the big issue. The sensor, what we recommend today, maybe tomorrow that will not be available. That is a big issue for us. But I will share all our data, this result, as US Share is not available in the Asian market. So no way we had to recommend EasyMed Plus for now. And also we recommend EasyMed GCU for now to use for the uric acid. So this is, only EasyMed Plus is recommended as a second option. But of course, US Share 2 would be the only recommended one. So I would request, I would share this data to all our partners, and I will request all of you to try to see whether these sensors are available in your local market. If this is available in your market, then you can make a standard package for you. Like in case of Bangladesh, we look for the sensor and we find this sensor available in Bangladesh. So for the Bangladesh, our recommended set is this one, because these are the available sensor in Bangladesh. So in the same way, you can consider the sensor what you can recommend in your country. So based on that, you can finalize your sensor. So I will, as I mentioned, I will share this data to all of you, and you can find your standard in your country. So thank you very much. And I think I took a long time, actually. So we will go for the panel discussion from now on, and I will pass the mic to Professor Ashir. Ashir, it's your turn.
Oh, thank you very much. Am I audible? Yes. Okay, thank you. So just let me check the time. So I have 20 minutes. Do you have to finish by 5, Maruf Sensei? Maruf Sensei, am I audible?
Yes, yes.
Okay, so
Also, you have 20 minutes, right?
20 minutes. Okay, all right. So everyone, I think excellent presentation, excellent information. I find it very, very valuable. The reason I found it valuable because we had 7 presentations from 6 countries. I was so happy and thrilled to see that the discipline, the area that PHC has been introduced in different disciplines. And I should say this is a PHC Portable Health Clinic ecosystem. So why Portable Health Clinic ecosystem?
Ada? Dia ada patient. Oh, tapi dia dah keluar.
Okay, I think somebody is
Memang.
the person from Thailand, maybe some noise is coming. Like the first presenters talked about how we can apply PHC in MCH, mother and child health. So, and the second one came from China. They look at PHC in diabetes, retinal diabetes, a new area. And the person from Indonesia, they talk about the standardization. They used FHIR and they did all this interoperability testing with different communities, which is very wonderful. And the fourth presentation from Malaysia, they went to the remotest area where almost like the network is not available. So they used a portable health clinic in a very, I should say, in a low resource setting, and they shared their experience as well. And the person from Thailand, they brought portable health clinic in campuses, academic campuses, and they developed a model, social business model for they call it Genki Campus Initiative. And the last presentation came for the quality of the devices, and they tested in Kyushu University. So I can see the panel, the speakers actually covered different disciplines from different area. So I have only 17 minutes left since there are 7 participants. I would like to ask very quick question, quick answer model so that we can make sure that I can reach to everyone. So I will go with the same flow, the first 2 speakers, Nusrat and Professor Kikuchi. So you guys worked on maternal child health. It looks like very, very sensitive area and very important area as well. And you studied in Bangladesh and as well as started working in Zambia. So do you see any cultural issues when you provide maternal and child health by using portable health clinic? Kikuchi Sensei or Nusrat, anyone is okay. I don't see Nusrat, so Sensei.
Okay, thank you very much for your question. Yes, cultural issues for maternal and child health. Yes, there is. Yes, there are. Especially when Yes, when we consider about the like women in Bangladesh, they have very sensitive regarding being watched by male healthcare providers. So it is maybe a challenge for us to set gender point of view in the health checkup. So like we have two male and female health workers in the field because if only it's only male health worker, maybe women they reject being
I see.
checked by those men. So yes, we have to be very careful about that. So the information from the local people about those information, what is sensitive for pregnant women and what is okay. So that is really, really important things.
Thank
It
you.
is
Thank
the
you.
first thing I have to collect such kind of information.
I see. So we have to be very sensitive about like who to send to the
Mhm.
woman.
Yes.
Wonderful. So did you find any challenges like for using this ultrasound device? The reason I'm asking, I was last month I was in the United States and I was talking with a partner from India. So when I was explaining portable health clinic, they are planning to use portable health clinic in 50 villages in India. So when I was talking about the ultrasound equipment, they told me that they cannot use ultrasound in India. The reason is it is banned by the government that you cannot use ultrasound. The reason was if you know the gender before the childbirth, and if it is a like baby girl, there is a situation that they might kill the baby. So that's why they banned it by policy that you cannot use. You should not know the gender before you are born. So that was something very shocking to me. Like we have so many things to consider. Did you find any similar stories in Zambia or in Bangladesh? Like
Yes,
that
in
shocked you?
Bangladesh, yes, we heard of that. In Zambia, no, I don't believe they have such
Kind of thing.
such regulation or something like that. But yes, so in Bangladesh, so I think we cannot tell the gender of the child. It is not, yes, of course we can use ultrasound in, if it is a medical person, they can use it in the field also. So the challenge is rather to find the person who can go, the medical person who can go to the field and then provide screening. So that is really difficult. So finding such kind of very specialized person is really difficult. And so we found, fortunately, she is in Dhaka. So every time we ask her to take get a trip, have to come to the field within 1 or 2 days. And so that is maybe very, it's a difficult scheduling or yes, such kind of difficulty we have.
Okay, thank you. Thank you so much. I want to go to Professor Hu.
Yes, I should say.
Okay, hi, Hu Sensei, how are you? Thank you for introducing this retinal diabetes, I think diabetic retinopathy. So I saw these excellent sensors that you're using, and in the field for portable health clinic, we have found so many like very small smartphone-based technology as well to take a photograph of your retina. Did you have any chance to see the quality, as Professor Maruf was mentioning? Like quality is something we have to be very careful. So those just they put what they do, they put an extra camera on the on your smartphone, they take a picture and they analyze this thing. How do you explain the quality of those kind of software based retinal diabetes identification.
Okay. In my understanding, actually, in last 2 years, we have tried to use three division what is this 3D printing technology to make a prototype of sensor which can take find those picture with your smartphone. But finally, we found it is very hard to use this kind of camera. So at present, we still use the traditional type of finder's camera, the professional medical devices. I think for now, the quality, the quality of the hand-handled camera for taking finder's picture is not qualified for the medical use. But in the future, I think it will help health worker to do the DR screening in a more easier way. Is that answering your question?
Yeah, of course, yeah. I just wanted to know. I was very much curious about that. It's another very layman question. I'm not a medical doctor, so I really don't know. So when we see this, like the presence of diabetes on your retina, does it also can we see it in normal blood as well?
You mean other abnormality of the finders?
So diabetes is a disease. I mean, one symptom that it can appear on urine, it can appear on your blood, and now we are seeing that it can appear on your retina as well. Are they like the same diabetes, or they are the two different diabetes which you can see in your retina and we can see in your blood?
Yes, the same diabetes. Actually, it has very close relationship between the DR severity of DR and the duration of diabetes.
I see.
Yes,
is there any relationship, for an example, which appears fast with earlier than other? Like you can find the symptoms in retina earlier than your blood. Is there any findings on that?
Yes. One of our papers published this year is discussion this topic you just referred. If you are interested in, I can share with you and Professor Maruf and other colleagues who are interested in this topic.
Yeah, thank you. Definitely we will do. So I'm going back to Lutfan, Indonesia. Thank you for sharing this excellent information that you are doing. You're using international standards and you're using it in your community as well. Are you from the medical background or from the IT background, Lutfan?
From medical background.
Medical background. Okay. So who developed this fire? Is it your own engineers or you outsourced it somewhere?
Well, we have a technical team as well, which have been trained to understand this fire things. Yeah.
Okay, great. If you can connect us with them, we really want to discuss, and we will also want to see, because we are currently developing PHC 2.0, and we'll be very much interested to share our knowledge and exchange our views as well. And at one point, if we can do the interoperability testing, I think that will be very interesting as well.
Yeah.
So congratulations, wonderful work. Thank you very much. I don't have any particular question, but I just wanted to say thank you for your work. And Professor Helen, very nice to know that in Sabah, we have enough space. Only 2% of Bangladesh population are there in Sabah. Please let us know if you need any population. We are ready to export. We have so many people in Bangladesh. So I think we can exchange that if you need them. So totally, you have mentioned that 1,394 people you have served. So is it like throughout the whole journey, or is the total cumulative number, or just today?
No, it's throughout, but basically this is the one that is reported in the PHC. Yeah, so that's
I see.
throughout. But each time we go, we only see 50 to 100 because the community is the density is so low. So each time we go to a community, some even travel 10 kilometers to see us, you see? So very few patient. And that's why the number is so small compared to other groups, you know? Yeah.
So is it like,
Yeah.
do you make a pre-announcement to everyone?
Yes. So we make announcement to the head of the villages and then in the radio and so on. Yeah.
Okay, all right. So they do pre-register, or on the spot they come?
Yeah,
And
on
you
the
know that
spot.
how
No.
many,
Yeah.
on the spot, you know how
On
many
the
people
spot
are
and
there.
then.
Okay, so do you have any lessons learned? I think there are so many unreached islands also in Indonesia, I believe, in Papua New Guinea, where there is no internet, and also some low resource settings. So from
Yeah.
your learning, if you have one sentence to give, provide for those who wants to use portable health clinic in low resource settings, what should be your advice for them?
I think portable health clinic connects the dots to a better healthcare, you know? So because data collection is so important, and only then we can prove that, got evidence that this isolated community is neglected, you see. They're so small. Some, like in Malaysia, just for your information, they only build clinic if there are more than 2,000 population. So because it's so diverse, dispersed. So that's why there's some area, they have no clinic. They can be as far as 80 kilometers away from the nearest clinic. Yeah. So
Wonderful.
PHC connects the dots to a better healthcare for isolated communities.
Thank you. Thank you very much. That's a good word. I think we can pass this comments to others as well. Connecting the dots. Wonderful. Ms. Saw from Thailand, wonderful work that you have. We have tested our Genki campus in several areas in Bangladesh, and also we had a collaborative work with AIT. Thank you for sharing your resources. And at the time, we received so many advices from Dr. Foyas as well. Currently, he probably couldn't attend today, but we received so many exciting
Professor
suggestions
Ashir.
from.
Ashir,
Oh my
Faiz
goodness!
is on.
Hello,
Wonderful.
you're
Thank you,
back.
Faiz
You're
bhai.
back.
I've been
Hello.
masquerading as Professor Rafiqul Islam for a while, but I just changed the name as well. So
Oh, I see. So you are Rafiqul Islam. I see. So now you're Faiz Shah. So wonderful work. Congratulations that you are expanding the model to other campuses as well. Unfortunately, I have only 2 more minutes. So in one sentence, Dr. Faiz, can you tell us your experience, and if you want to add one sentence after Ms. Saw's presentation?
absolutely. I think we, as Soy has explained, we are now taking this whole idea into social business mode. And I think that is probably what we wish to present next time. If the university buys into this and it becomes part of the university healthcare system, I think it will be a major endorsement of all the wonderful work that yourself and all friends have done. So I hope that's useful. The maps were something that we thought would be very easy to understand. And there's also something that is visually extremely simple to follow. So if you've got a series of maps coming every semester, even non-technical observers can see that an incomplete circle means there's something not right. And so they can follow through. So we've tried to make it more intuitive. We've tried to make it more user-friendly. So hopefully that will
Yeah,
help.
wonderful. Thank you. We would like to discuss more. Thank you so much. And finally, Maruf Sensei, thank you so much for sharing all this information, which is very important. Like, in rural areas, in different locations, people go by the cheaper devices, but they don't know about the quality. So Maru Sensei, you showed the comparing with the Japanese standard and with the devices that we brought from different countries. Did you have any analysis about cost versus quality?
Thank you. This is very important because in PHC, we try, as I mentioned, we try to get quality sensor, but with low cost. This is always challenge. So that's why actually in our analysis, when we make the priority, when we give the priority for our recommendation, that time actually we consider the price. Like I mentioned in my presentation, in case of hemoglobin sensor, we find that the most expensive sensor was HemoQ. This is globally acceptable sensor, but we find that in terms of quality, there are some sensors, even they produce better result, but the price is just 1/10 or 1/20th of that. So that is very important. That's why I hope I will share our data to all our partners so that they can see the quality as well as the price is also mentioned there. So they can consider the affordable one for them.
Thank you so much. So if we can draw two more graph, one graph which is actually the trade-off issue, price versus the quality, I think that will be very interesting. And the second one, I would like to see whether the popularity versus quality. So some sensors are very popular in that country, but we don't know. So the impact, the negative impact they are creating. So if we can add another graph, maybe popularity versus quality, that would be more interesting. So
yeah, thank you.
think
Actually, the first one is easily we can do graph price versus quality. But about the popularity, we have to get support from our partners so that we can know the situation there. So thank you very much.
Exactly. So I'm just 2 minutes over the time. I will get back to you. So in conclusion, as I have mentioned, today's panel, we found an ecosystem, like all of like different functionality, different disciplines of PHC. Thank you very much, all the speakers. You have done an excellent job. I'm happy to be your panel moderator.
Thank
today.
you. Thank you very much, Ashish Sensei. And actually, we are at the end of our program. And we are very happy, Faiz Bhai. Thank you very much that you could be here. Finally, we could see your face. So it's always good to see all our partners. And I hope we will have this annual program definitely. But in between, if we can make some opportunity, maybe we'll meet once again. So before conclude our program, I would pass this mic to Mariko Sensei to make the closing remarks. But I don't like to miss Yokota Sensei. Please give me one word from your side because you are there.
Thank you, Manu Sensei. Yes, I was listening all the presentation, but I'm very sorry to have disturbed by other session. It was really impressed that the improvement of each presenter's content compared to the last time. So I think very progress I could see. And thank you so much for continuing to collaborate together for this project. Yeah, thank you.
Thank you very much. So I will pass to Mariko Sensei. Before that, thanks to every team, all team from my side. I very much adapt to you. Every time, whenever we have this occasion, you all cordially participate in this program from China, Indonesia, Malaysia, Thailand, all countries are participating here. So thank you very much from my side, and I will pass to Mariko Sensei.
Thank you. Almost time is up, and but I want to say thank you. Thank you for joining us today, and the staff of QAOS and TEMDEC. Thank you very much for your support. And I appreciate all speakers. Interesting presentation and informative presentation and effort to share your findings. And with our speakers and with the support of member of PHC module, QAOS, Kyushu University, and many others, this year's PHC special session of Kyushu University Asia Week 2024 was able to be held with success. And I would also like to gratitude to all guests and the audience for your attention. And yeah, so finally, I want to say our mission. So our mission is to promote the creation of the new research and the businesses that contribute to achieving access to reasonable healthcare services for many people, regardless of their social and economic conditions. So I strongly believe the importance of the equity in health and healthcare. So we hope for more and further development in each region's activity by sharing experiences and findings in this session. I would like to conclude by saying that I hope to see you all again, hopefully next year. Thank you.
So with that, we will conclude. See you next year. And
Yeah,
before that,
thank you.
thank you
Thank
so
you so
much.
much. Bye-bye.
Thank you. Bye.